Thank you so much. What a great question. We are preparing exciting session at the American Academy of Neurology this year in Chicago, where we're going to discuss different neurologic spells with headache section, epilepsy section, and vascular neurology sections. I am a vice chair for headache and facial pain section of American Academy of Neurology. And I'm so glad that we are talking about it with our colleagues because migraine, epilepsy, and stroke can come as a spell, as an episode. And very often, headache is one of the symptoms of other conditions. So how do we distinguish it? And we know data. For example, epilepsy can come with headache post-ictally in about 20% of cases, according to some literature. And people with stroke during having stroke could have a headache. Generally speaking, migraine known for headache being in 95% of cases is after other neurologic symptoms. So when people have changes in vision, changes in sensation, sometimes weakness as neurologic symptom, we do think where headache fits in this time-wise. Another distinction will be that with migraine, spread of neurologic symptoms, generally speaking, can be more slow. So if with seizure, epileptic seizure, or with stroke, neurologic condition develops the way that symptoms come very fast after each other. With migraine, it generally speaking, which I keep repeating because there is always exceptions, it comes more in slow fashion. People with migraine more likely to have sensitivity to light and sound. We also take it in consideration. And then we know some known in migraine visual changes such as scintillations or this spreading very slowly around visual fields. We call it evolution of visual symptoms. So there is a lot of art to that, but we also have exciting testing such as imaging and EEG and so on to help clinicians to distinguish what is happening in this particular case. When we see person with overlapping symptoms, it brings me to think about our international classification of headache disorders. Right now we have ICHD-3, and we all working as headache community, and international Headache Society has committee led by Dr. Godsby, whom I'm very grateful to be trained in headache medicine as his fellow in the past and mentor even now. And we working on the next one, but ICHD-3 is something that distinguishes different conditions for us. And with migraine, we have to exclude other conditions that can lead to headache. To exclude those other conditions, we would use imaging, and example would be MRI for epilepsy, and to do proper testing, we would consider EEG when needed, and this way we can treat the person appropriately. Now, there are interesting diagnoses and thankfully not very common that definitely some overlap with things like hemiplegic migraine. Hemiplegic migraine is migraine, but with symptom of weakness and muscular weakness. And some types come with genetic component, and we can do genetic tests, but some we don't know what gene is responsible for that. And then it could be overlap in genetics between some genes in migraine and epilepsy. So we cannot rely so far on genetic components. So when person comes in urgent emergency setting or in the clinic with new weakness, we do have to exclude with epilepsy and we have to exclude stroke at least this time. And then if person gets diagnosed, we excluded epileptic seizure and we excluded stroke. We can then, if next time it repeats itself and it's stereotypical and we know it's hemiplegic migraine, we just treat appropriately with very well-known and established treatment for hemiplegic migraine when person has migraine, which shows with this muscular weakness as one of components.